Hi guys, I'm Mind Rentgen, welcome to the channel, and today we will be talking about heart blocks. So what is heart block? Heart block is essentially a delay or obstruction in conduction of the electrical signals from the sinoatrial node through the atrioventricular node and down into the ventricles to cause ventricular contraction. Now this block can be at the level of the sinoatrial node, at the level of the atrioventricular node, or downstream in the ventricles themselves. But today we're going to concentrate on the atrioventricular node and go through the so-called AV blocks. And there are three main types. There is first degree, second degree, and with two subtypes, Mobitz I and Mobitz II, and third degree AV block, also known as complete heart block. Let's start with first degree heart block. So this is supposed to be a normal ECG trace as attempted by me. So we've got P waves, QRS complex, T wave, P wave, QRS complex, T wave, and P wave represents the depolarization of the atria, and the QRS represents the depolarization of the ventricles, and the interval between the end of the P wave and the beginning of the QRS complex should be less than 200 milliseconds normally. And then first degree heart block, what we see is the interval between the P wave and the QRS is prolonged. So it will be over 200 milliseconds, and it's going to be constant before every QRS complex. And 200 milliseconds is usually 5 small squares on ECG paper for reference. And first degree heart block by itself, with no other ECG abnormalities, doesn't cause any symptoms, is usually quite a benign finding, and does not require any artificial pacing. So, as we mentioned at the start, second degree heart block can be divided into two types: Mobitz I, also known as the Wenckebach phenomenon, and Mobitz II. So, with Mobitz I heart block, this is once again the normal trace with the constant PQRS. PR interval is the same each time. With Mobitz type 1 block, what we get is normal PR interval, then PR interval that's slightly longer, then PR interval is longer again, until finally the P wave does not conduct at all. So we get no QRS complex, and then get P wave again, normal PR interval usually, QRST, and then this sort of pattern will repeat itself. So the PR interval gets longer and longer and longer until the beat is just completely dropped. And Mobitz type 1 block in a symptomatic patient may require artificial pacing. In the asymptomatic patient, it may not require pacing, and depending on the cause, may even be reversible. So, second degree heart block, Mobitz type 2, and by the way, I need to get better drawing these QRS complexes. Look at this, this is a mess. But anyway, Mobitz type 2, what we get is, we get normal P, QRS, T, and again normal P, QRS, T, and then all of a sudden we get P, nothing, and then P, QRS, T, P, QRS, T, and then you get P and nothing again. So what we get is a fixed ratio of conducted P waves to non-conducted P waves, and this can be 2 to 1, it can be 3 to 1, and normally the PR can be less than 200 milliseconds, so it can be normal in duration, but all of a sudden we'll just get a drop beat somewhere, and usually the same pattern of conducted to non-conducted P QRS cycles will repeat itself. And this is quite a dangerous type of heart block because it can progress to complete heart block and result in sudden cardiac death. So any patient that you see with Mobitz type 2 block needs referral to cardiology urgently for a permanent pacemaker. So the last type of heart block to talk about is third degree heart block or complete heart block. And in this type of heart block, so the top trace is still your normal ECG, and the bottom trace, I've simplified it a little bit and I've deleted the T waves, because what I want to show you guys is in complete heart block the P to P intervals will be regular and the R to R intervals will also be regular, but there's no fixed relationship between the P and the QRS. Alright? So the P waves and the QRS complexes just go their separate ways and do their own thing. And the reason why that happens is in complete heart block, there's no conduction through the AV node into the ventricles. And the way the heart deals with that is essentially it produces what's called an escape rhythm. So a rhythm generated within the ventricular conduction system to cause contraction of the ventricles, and the P waves become completely irrelevant. So the SAN will still produce electrical signals, but they just don't get conducted through to the ventricles. So they don't really do anything. The reason the patient is still alive is because of this escape rhythm arising from the ventricles themselves. And this is a very dangerous rhythm because the escape rhythm of the ventricles is not reliable, and the patient can just go into ventricular standstill. They can just completely stop having ventricular contractions, and this can cause sudden cardiac death. So any patient with complete heart block needs a pacemaker urgently. So they need to be immediately admitted and have the pacemaker ideally within a few days, or if symptomatic, even earlier than that. So in summary, we have three main types of AV block: first degree, second degree, which can be Mobitz I or Mobitz II, and third degree, which is complete heart block. First degree, we have a constant PR interval, which is prolonged over 200 milliseconds, and there is a QRS complex after every P wave. In second degree, Mobitz type 1, we get a prolonging PR interval, gradually getting longer and longer until finally a beat is dropped. Mobitz type 2, we get a constant PR interval, which is normal, and then every so often there's just a drop beat without any warning. And in complete heart block, there's just no relationship between what the P waves are doing, what the QRS complexes are doing. The P waves can be sometimes buried within the QRS complexes because of this, or within the T waves, makes them quite difficult to see sometimes. And basically the higher grade the block is, the more dangerous it is. And the way I remember, especially Mobitz I and Mobitz II, Mobitz I gives you a bit of a warning, right? So you get a prolonging, so you can see where this is going and predict, oh, the beat is going to be dropped. Mobitz II, more unpredictable. You don't know when the beat is going to be dropped until it just goes and is not conducted. And it has a very high risk of progression to complete heart block. And for Mobitz type 2 and complete heart blocks, you definitely need a pacemaker urgently for the patient. Mobitz type 1, in some cases you might not, and first degree, usually you don't need to do anything if there are no other abnormalities on the ECG. I hope you enjoyed the video. If you did, please give it a like, subscribe to the channel if you want, and I'll see you all in the next one.